Okay, my name is Dabere Nigatu. I'm presenting maternal health service uptake can improve skin to skincare practice in Ethiopia, result from national survey. I'm a PhD candidate and assistant professor at Bahar University. Here is my presentation outline. It follows introduction. I end up with showing my references. As to the introduction, skin to skincare is among the record intervention for child survival. According to WHO, skin to skincare is defined as placing the naked baby on mother's bare abdomen or just immediately or in less than 10 minutes after birth or soon afterwards. Studies note that skin to skin care for preterm or lower weight is associated with reduced mortality or morbidity. It is associated with improved maternal infant attachment, improved infant growth, and it enhances early initiation of breastfeeding. Overall, skin to skin care is an easy to practice method, but with substantial benefit for both preterm as well as full-term births. It's also effective and a safe alternative to conventional care available for preterm or lower weight babies. In Ethiopia, skin to skin care practice is first introduced in 1990s at Rambas Hospital, then it scaled up to other facilities across the country. In settings like Ethiopia, where up to 52% of childbirth takes place at home, only facility-based implementation of skin to skin care may not be adequate to bring the desired child health outcomes. Hence, in 2030, Ethiopia launched a community-based newborn care practice, which includes skin to skin practice. Since then, skin to care practice becomes high-impact newborn care package at both facilities as well as community level in Ethiopia. Thus, both national and subnational research is becoming a cornerstone for strategy to monitor progress at a desired level. However, except few pocket studies done so far, there is inadequate data on the proportion of skin to skin care at national level. Therefore, the objective of the study is to determine the proportion of skin to skin care practice at both national and regional level. The second objective is to identify factors that affect a skin to skin care practice at national level or in Ethiopia. Coming to the methodology, the data we have used is the 2060 EDHS. EDHS is a national representative household survey with the sample size and the sampling procedure. EDHS uses stratified two-stage cluster sampling technique. In the first stage, enumeration households are selected. In the second stage, a fixed number of 28 households per cluster were selected. Finally, we have analyzed the data with a sample of 7,488 weighted sample of index live births. As to the study variables measurement, the outcome variable for this study is skin to skin care practice, and it is measured by a question which is stated like this. Immediately after birth, was the child put directly on the bare skin of your chest? So these questions are forwarded for mothers. Then the possible options, response options are yes, no, or don't know. Here are the explanatory variable list that we have used as a factor variable. Coming to the data analysis, the data was analyzed using Stata version 14. Data weighting was applied as recommended by the DHS program, and we have used survey sales data command to declare complex survey. And whenever we run estimators, we use SCVY command. A multivariable logistic regression is used to identify factors. In the multivariable logistic regression model, a p-value less than 0.25 applied to select candidate variables, and for all variables, odds ratio with 95% confidence interval were reported. Presence of association was declared, p-value less than 0.05. Ethical consideration, ESG survey protocol was reviewed by the national as well as the international review board of the ICF International, and we got permission from ICF DHS program to use the DHS data for this analysis. Coming to the result in the discussion, here are the socio-demographic characteristics of the mothers. Majority of the mothers, about 80%, are in the age range of 90 to 34 years. And coming to the proportion of skin to skin care at national level, it is 24.3%. And this national level proportion is higher when compared with study done in India as well as Nepal, while it is lower than the proportion reported in Sri Lanka. Maybe the difference may be when compared with the Sri Lankan study. The Sri Lanka study is a facility-based study. Because of this, maybe the variation explained in such a way. The proportion of skin to skin care practice, this graph shows the skin to care practice by regions. So the highest region in terms of skin to care is Addis Ababa, followed by the Dabere and Dabere, while the lowest region with skin to care practice is Somali region. Maybe the regional variation may be explained by due to the variation in the initiation and scale-up of community-based newborn care practice across regions. It may also be due to difference in health infrastructures. For example, Addis Ababa and Dabere are the region with highest skin to care practice. This may be due to most of the Addis Ababa population, as well as the Dabere populations are urban, while the other regions are a mix of urban plus rural. And predominantly the other regions may be the rural residents is very high. Coming to the factors, we have analyzed the association between different social demographic variables as well as health facility variables. AMC is positively associated with skin to care practice, so it may be explained by because the role of AMC, this shows that the role of AMC counseling on immediate newborn care practice, including skin to care practices. There is also a study which shows similar results, which is reported in Ethiopia, the positive association between counseling and skin to care practice. The other study, qualitative study, remarked that AMC awareness as a feasible remedy to overcome knowledge and attitude-related barriers of KMC practice in the community. So this may be the possible reason why this AMC is positively associated with the skin to care practice. The other factor which have significant association with skin to care practice is health facility delivery. So giving birth at health facility can give a better chance for health professionals to assess the newborn condition as well as to suggest and help the mother to initiate skin to care practice. Because of these reasons, those women which give birth at health facility have practiced skin to care practice than those mothers who deliver at home. There is also a similar study which shows association with the current finder is cesarean, which is negatively associated with skin to care practice. This may be justified by these reasons. One is women with CS may be at a difficult position to put the newborn in skin to care contact because of two reasons. One, it is demanding for longer time to recover from anesthesia. The other is the CS site may be painful and they need time to heal. There is a systematic review which shows that pain and fatigue as a top-ranked barriers of KMC practice in the middle-income countries. As to the strengths and limitation of the study, this study is a national representative. We have used a national representative data with a large sample size, and we have also included only those most recent births, which likely minimizes the recall bias. As a limitation, still, this is a survey study which is not free of recall bias, and we haven't analyzed the birth weight data as a significant factor because of large missing. About 85% of the birth weight data is missing in EDHS. Because of this, we take it out from the analysis. And instead of this, we have used the proxy indicator baby size. As to the conclusion, the proportion of skin to care practice is low or was low in Ethiopia with a significant variation across regions. Significant factors are maternal service uptake, such as ANC, and facility births had positive association. In contrast to this, giving birth by CS or via CS is negatively associated with a skin to care practice. As to the recommendation based on the findings, we would like to recommend the following. One is a community-based promotion of skin-to-skin practice at a full scale is very important to increase skin-to-skin practice at national and regional level, and also to minimize the existing regional variation across the country. It's also important to increase ANC coverage, and increasing ANC coverage and strengthening ANC counseling is very important, with a focus on the skin-to-skin component into the ANC package. Finally, we would like to, or I would like to acknowledge the ISAFE Micro International, or the DHS program, for allowing us to use the 2060 DHS dataset for free. And lastly, I would like to thank the ESOG for organizing this conference in the face of the global pandemic. Thank you for your attention. Here are my references.